So Dr. Mark Cleon of New York Orthopedics is a board-certified orthopedic surgeon who is fellowship trained in sports medicine and dedicated to treating athletic injuries of the musculoskeletal system, with a special focus on shoulder, elbow, hip, knee, and foot of ankle injuries. Dr. Cleon employs the newest techniques for knee ligament reconstruction, cartilage repair, regeneration, and meniscal transplantation, and has expertise in arthroscopic rotator cuff repairs and shoulder stabilization procedures. He's an experienced orthopedic surgeon who has been in private practice for almost 25 years in New York City. He earned his medical degree from the Icahn School of Medicine at Mount Sinai and completed his orthopedic residency at Mount Sinai Hospital in New York. He completed a fellowship in sports medicine at the University of Chicago, Illinois. Dr. Cleon is the medical director of the New York City Triathlon and has completed 11 Ironman triathlons and 15 marathons. Dr. Cleon has been recognized by Castle Connolly as a top doctor in 2014, 16, 17, and 18. And today he's speaking on the treatment of articular cartilage of the knee.
We all good?
I think we're all good. Go ahead.
All right. Thank you for the glorious introduction. I'll add into that I've now completed a multitude of ultra marathons, and that's kind of where I'm leaning these days. So articular cartilage injuries, I think, are a little close to my heart, although knock on wood, nothing's happened to me as of yet, so that's good. So let's jump into this, because I think you've heard some talks about ACL and meniscal injuries, but kind of the hidden piece that poses the most difficulty for orthopedic surgeons right now is the articular cartilage. We've got great solutions for ACLs. We've got pretty good solutions for meniscal, but articular cartilage injuries are another beast that we have to deal with. So the pictures that I have here kind of show you pictorial documentation of what the ultrastructural aspect of cartilage looks like. Then a little bit more of a macro, and then an arthroscopic picture of what the white, glistening, beautiful substance that lines our joints. It's smooth, it's uniform in layer. It essentially creates a frictionless or a low friction environment that allows for joint motion. Problems that come up, though, is that it's avascular. It is cellular, as you see on the picture on the left. This is the orientation of the top surface being, the joint surface, then going down to the subchondral bone region. And there's an amazing complex orientation of cells. There are flattened cells up at the superficial layers. They get a little squished, or a little bit more plump, and then they get really plump towards the bottom. But then there's this so-called tide mark between the bone and the articular cartilage, where really there's a barrier to blood supply. So that poses a huge problem, because we understand that bleeding is in essence our healing potential. So there is no blood supply to articular cartilage. There's no neural innervation. So interestingly enough, if you touch the articular cartilage, it's not really painful. It's the surrounding layers of the synovium, the lining of the knee, that are incredibly painful. The subchondral bone in the middle picture, again, is a structural component that helps to buttress, it helps to buttress that articular cartilage and gives it some of the mechanical properties that we'll talk about in a second. And then the white, beautiful, glistening, normal cartilage that you see here is what hopefully we all have and lasts us throughout our life. The big problem is that there's really low or no potential for self-repair. So when you injure this, that becomes a big problem. So normal articular cartilage is made up mostly of type 2 cartilage, type 2 collagen. We make this type of collagen once in our life, in utero. After that, you don't really make it anymore. So you're really plated to, once you injure it, you can't fix it. There are cells that are embedded in it, and they're mature cells. They have no real potential for division. So even if you disrupt them, even if you try to make them divide, it's very difficult in vivo, in the body itself. There's some extracellular matrix that kind of makes up this sponge-like configuration. It's composed of proteoglycans. These are proteins that have mucopolysaccharides that are attached to them that help attract water, because water, in essence, is the cushion inside of this kind of sponge-like collagen matrix. So water really comprises a vast majority of our articular cartilage, and there are changes that we see with aging and with injury. The biomechanics really is that it decreases friction, which we talked about. It distributes loading. So along with the meniscus, which again might have been talked about before, really acts like a tire that's laying on its side, that when you stand on it, it spreads itself out. Well, similarly, articular cartilage also function in a similar fashion. It does have a property called viscoelasticity. Viscoelasticity is a biomechanical property in which when you load it, it becomes firmer. So you can push on articular cartilage, as we do in arthroscopy, to kind of assess what it feels like. But if you're impact loading, like with running or something along those lines, it actually hardens and stiffens to help protect the joint. So you've got a low friction joint, you've got some other biomechanical elasticity to it, which helps protect the joint. And then you've got the meniscus to kind of share all of this. So when they work in conjunction, people's knees and articular cartilage last a lifetime. The spectrum of disease of this really can go from a single focal defect to then something where it's progressive to advanced degenerative disease. Interestingly enough, in 5 to 10% of individuals over the age of 40, we see these incidental lesions pop up. So at the time of arthroscopy, when we go in and we look for a meniscus tear, all of a sudden we see something that's not right in the articular cartilage. Probably asymptomatic, probably has been there for many, many years. And sometimes there's really no treatment for that. But we have to understand that it's often associated with it. And we'll talk about that in a second. Obviously, these cartilage injuries, as maybe was talked about before, where you have an ACL injury and the knee subluxes and the ACL tears, there's often concomitant articular cartilage injury that you actually might not see initially, but over a period of time, because the cells have been damaged just by the pressure and the impact, eventually these mature chondrocytes can no longer support the surrounding environment. They die, and then the extracellular matrix starts to disintegrate, and that's what leads people who have had an ACL tear, possibly 20 years down the road, to have some arthritis. So obviously acute trauma can cause this. Repetitive overuse. People would like to say that runners develop arthritis. Well, there's really no distinctive study that's out there that shows that long distance running creates an arthritic knee. I'll knock on wood again. 58, still running, have some aches and pains, but hopefully I don't have any changes that are going on in my articular cartilage. So there's a classic description of what cartilage looks like. So there's an outer bridge classification. So if you look at the 4 pictures that you have on the right-hand side, the first would be somewhat of a grade 1. Grade 0 would be normal. Grade 1 would be that there's some softening. This would be a probe that would be pushing on some cartilage, and you see a little bit of softening. Now, that's a very subjective evaluation of the cartilage, but that would, no real focal defects. The second stage, where you would have some superficial fissuring, you'd start to see some aspects of crab meat formation. The cartilage is somewhat cracking, but there's really no full thickness injury that's there. A grade 3 would be now this fissure is much bigger, and there's actually a focal lesion that's there. Grade 4, though, is actually, as you see on the right lower side, where there's a full thickness lesion and there's exposed bone. So treatment of these, which we'll discuss in a little bit, varies differently from the grade 2 to grade 3s to then the grade 4s. Advanced degenerative disease is where there's really a complete loss of the articular cartilage, usually on more than one surface. So this is a picture showing the femur here, which has lost a good amount of cartilage. And then we have what's called a kissing lesion, where also on the tibia, we've lost and we're down to basically eburnated bone. As you can see, these electron micrographs on the left-hand side, this is normal cartilage. We kind of talked about the superficial layer that's here with flattened cells, and they get bigger and rounder as they go down. Now here is a degenerative knee, where there's some fissuring, small fissures. The cells don't look anything like they do at the top here. These are cells that are starting to die and are unable to maintain the substrate and the extracellular matrix, and eventually this cartilage will break down and lead to fragmentation and possibly create that situation of osteoarthritis. So how do you make the diagnosis? Well, obviously, patients, clients come in, they have a history. I stepped down, I twisted my knee. Ever since then, it's been bothering me. Some people don't really have a history of any particular event, although it might be just one day, I woke up and my knee's been bothering me. Degenerative, again, this is a chronic injury that's been happening over a period of time. But often the presenting symptom of this, unlike some meniscal tears, is that sometimes there's not that much pain. It can be poorly localized, and most of the symptoms are related to the swelling, or what we call an effusion. So the difference between swelling and an effusion is fluid that has collected inside of the joint. Swelling would be soft tissue. It's commonly used, but we like to call it an effusion. So when there's a change in what looks like the knee looks very puffy, that's usually because of an effusion. And that's a reaction from some of the fragmentation of the cartilage. It becomes an irritant inside of the knee. It becomes like a piece of sand inside of a ball bearing. Some people, though, with an acute injury can actually knock off a large piece of cartilage. And in doing so, that piece floats around. So some people will say, my knee's been kind of swollen and it's been bothering me. But every once in a while, I get this sharp searing pain in which that piece, like a pebble inside of a very, very tight joint, gets caught. They might say after a second or two, if I can finagle my knee a little bit, it seems, to get better. And that usually is evidence of a loose body inside of the knee, and that can be from a cartilage piece. X-rays can be helpful in a young, healthy individual. They're usually normal. In someone who's 60, 65, maybe a little bit older, and they have some arthritic changes, you might see some asymmetry between one side of the knee and the other side of the medial compartment of the knee and the lateral compartment. We always get standing x-rays, and we always get x-rays of the opposite side, so we can get a gestalt and a comparison between the two. Here are two MRIs, and this is really where we can really evaluate cartilage injuries. This is looking at the knee from the side. What you can see here, this is the femur, that's the tibia. This is the meniscus, the front side, the back side, and this gray line that stretches all the way underneath is the articular cartilage of the femur, the articular cartilage of the tibia. The hardened bone, the subchondral plate, is the black line that's right here and right there. Now, this is a little bit different view in which it magnifies swelling. So you see an effusion, that's fluid where the arrow is. If you trace the articular cartilage as it comes down, there's suddenly a void that's there. That's a loss of cartilage. That's an acute single lesion that's there. And what you actually see is, if you understand that articular cartilage provides shock absorbing qualities to itself, when you lose it, guess what happens? The bone starts to see some pressure, increased pressure that it doesn't like. And this represents bone edema. It's often seen in an ACL as this knee subluxes and it bangs itself back in. We will often see classic patterns of bone edema. But certainly when there is a full thickness injury to this articular cartilage, you'll see an issue that is along those lines. So how do you treat these lesions? Well, obviously you can treat them symptomatically. There are some restorative procedures where we try and make new cartilage, and there are regenerative procedures, which are the new phase kind of treatment, protocols that we have, and we'll go through each one of those. So symptomatic, or what I would consider to be non-operative, this is always pretty much 99% of the time where we're going to start with a patient. First of all, if I've described to you that articular cartilage is made once, type 2 hyaline articular cartilage is made once in utero. If you lose it, we really have a difficult time making it. So patient education, patient's expectations of where their knee are is a primary goal. So if surgery is really not an emergent thing, then patients have to learn and understand where they're going to go from day 0, when we see them, to their end of their days when they don't need their knee anymore. And really getting those patient expectations in line with your treatment protocol really helps with the success of what you do. So you can see on the left-hand side, there's a litany of things that we can offer an individual to try and make their knee better. So obviously, I'm not a drug pusher, but non-steroidal anti-inflammatories. For individuals who have that effusion, that swelling inside of their knee, an oral anti-inflammatory is a great technique to try and reduce that. Have to understand that when you have an effusion, when you have 1 ounce of fluid inside of your knee, there's an amazing primitive reflex that actually goes through the spinal cord and comes back to the quad and shuts the quadriceps off. So although you might be doing great exercises to rehab that quad, if there's fluid inside of that knee, it's inhibiting your success or your treatment protocol. So we need to get rid of that. So obviously icing, which I've left out of here, which is a pretty benign treatment unless someone goes to bed with it and ends up burning their knee and has a superficial burn. Non-steroidal anti-inflammatories not given for the rest of their life, but given in periodic form, in a therapeutic dosing range. So someone who takes one Advil here, one Aleve there, doesn't really cut the mustard. You need to do it for a certain period of time to evaluate its efficacy. But they can be very helpful in terms of rehabbing and getting rid of some of the inflammatory event that's going inside of the knee. Now, pain medications. Obviously, someone who's had an acute injury inside of their knee, you do want them to be able to start some of the exercises. So we do give pain medications. But again, in today's world of opioid overdosing, we're very careful about this. Obviously, long-term goal for an individual, you see here I've written down for every pound you lose, that's 4 less pounds biomechanically the knee sees. And also, if you do all the physics, for every pound you lose, it's 6 less pounds the hip sees. So we should never tell a patient, look, you got to lose 30 pounds. I mean, that's all it is. You need to start them on a realistic goal of 5 pounds and just conceptualize it that 5 pounds is like taking 20 pounds off of the knee. And for certain people, certainly with degenerative disease, that's a great thing to do. Physical therapy, obviously, is a mainstay of treatment, getting their quads back, getting their core back, getting their stability back. I see a lot of runners just because of my background, and I can tell you that vast majority of runners are weak in their core, their hip abductors. And it's very easy to test, and it's very easy to diagnose. And certainly individuals like this need those stability muscles, so it's very important. Injections. When are injections indicated in these scenarios? Well, cortisone injection, someone who's intolerant to oral anti-inflammatories, cortisone injection is a great option. Not multiple, a single time here and there, once every 6 months, once every year, can be a real benefit to getting someone kind of up over the hump. PRP, platelet-enriched plasma. What's the concept behind this? Well, amazingly so, taking platelet cells plus some of the growth hormones and enzymes that are contained within the platelets in the plasma, once re-injected inside of a joint, can actually promote some aspect of healing. Now, this is somewhat controversial in these days. There's been some recent research that actually shows that PRP injections are actually better than a cortisone injection in terms of long-term, but they don't actually make new cartilage. So there's no reason that a PRP injection should be given to say, I'm going to make you new cartilage. It just doesn't happen. And we'll talk about that in a second. Viscosupplementation, lubricant, Synvisc, Orthovisc, Euflexa, Hyalgan, these are all meant for degenerative diseases. They're a component of synovial fluid that helps with lubrication. I often like to say that it somehow, if the cartilage cells inside of your knee are like the guys and girls at a frat party when they run out of beer, injecting that stuff into the knee kind of gets the people dancing again, gets the knee happy. It does do well with low-level symptoms of osteoarthritis. Obviously, we can never leave out bracing. So bracing can sometimes afford stability. There are unloader braces. So if there's a focal lesion on one side of the knee, we can use a brace to actually kind of somewhat alter the mechanical axis of the knee and unload that area. But again, these are short-term fixes for sometimes very complex problems. And obviously, for someone who has a degenerative knee, an ambulatory assistive device or a cane can be a lifesaver. Now, it's very difficult to convince someone to walk around with a cane. Number one, if you live in New York, you become a victim to a certain extent. It's a terrible thing to say. But again, biomechanically, it really leads to decreasing that area and can alleviate a lot of the pain. So what do you do from a surgical standpoint? Well, after you've exhausted conservative management and people are not feeling any better, or if there's a concomitant lesion. So again, you've gone in, you're doing a meniscal repair, and lo and behold, you see a lesion in the upper left-hand corner and you go, oh boy, what do I do now? Well, So again, you violated, this is an outer bridge 3. It might even be a 4, because if you go over to the right-hand picture in the top there, you start to see, as I always call it, Pandora's box. Once you start shaving it down, next thing you know, there's exposed bone. Now there's an outer bridge 4. It's a small lesion. And way back when, in the 90s, some very ingenious surgeons developed a process of what's called a microfracture, basically taking a pick and making these holes, as you see here, essentially stimulating the bone marrow, bringing vascular channels to this region. In small lesions, probably less than a centimeter, this can be helpful in terms of restoring the smooth articular surface. But you have to remember, type 2 collagen is not produced here. Type 1 collagen is produced. That's fibrocartilage. It tastes the same, smells the same, looks the same, but biomechanically is not the same, and it doesn't last a lifetime. These microfractures, depending upon the size of the lesion, you'll treat them non-weight bearing. You'll attempt to do some range of motion exercises with them, but it probably takes a good 4 to 6 months for some aspect of maturation and ability to go back to impact loading activities. There are certain lesions, which we talked about, less than 10%, that we'll find that we just don't know what to do, because that's really not the primary pathology. So we have to be careful about some of these. If you leave some of these alone, they can progress. So sometimes it's a little bit of a dilemma once you get inside of the knee. So microfracture is a good procedure for a lesion that's probably less than a centimeter squared. Breaching up to 2 centimeters, you start to fall into a different category, which we'll talk about now. So here's another procedure, restorative procedure, where these can be done arthroscopically, but also can be done as a mini open procedure. This is an osteochondral transplant, or what's called an Oates procedure, or what's called sometimes a mosaioplasty. So the bottom picture, what you're seeing here is someone who had an articular cartilage injury. And what we've done in the upper picture is we've taken from a non-weight bearing area. We assume that it's non-weight bearing and it's not really that functional, the lateral femoral condyle. We use a device that takes out a plug of bone and a plug of articular cartilage. And we implant that into that region. The concept being is that with some of these articular lesions is that the subchondral bone, that tide mark, has been disrupted. And if you were just to kind of create a healing response, a microfracture, it's like doing that in a dent in a car. You're really not restoring kind of the beautiful contour that Mother Nature gave us, or evolution gave us. So in doing this, we're taking something, and this is not the final stage, you don't leave this where it is, but you impact that into it. So now you've got a bone and chondral kind of transplant. It's an autograft. It's from yourself. Viability is very good with these, but you also have to understand that with small lesions, okay, so it's less than a centimeter, and I take it from up over here and I put it down over there. The only problem is that the contour of the articular surface has a little bit different radius. So now you're taking an imperfect object and putting it into, where you want it to be. So yes, it looks nice, but it's not exactly the smoothest area that's there. And specifically, if you go up into a bigger lesion and you start to put multiple plugs in, the reason why it's called a mosaioplasty is because it looks like a mosaic. Again, you've restored the macrostructural aspect of it, but you're really having recreated the beautiful Teflon smooth coating. These do work, they are successful, but you have to be careful about matching the anatomy and getting the right individual for this. So again, less than 2 centimeter type lesions. So what do you do when the lesion's bigger than that? Well, we do have something called mega oats. Now, this is actually where you're taking from a cadaver, a fresh frozen cadaver, where we are transplanting a larger piece into an area. Now, the good thing about this is that when you get the allograft piece, it actually, we match them up via MRI and CT scan. So we get someone who's actually pretty close in terms of anatomy. And we do a lot prior to cutting the plug from the cadaver to put it into, the patient's body to make sure things match up. So the simple blue line has given us our orientation, so we try and match things up. Again, not going to be perfect, but you're restoring, you're restoring articular cartilage into a relatively large lesion. And this is called a mega-oats. And they have been very successful, but patient selection for something like this is really very important. These are not meant for people who have arthritic knees. This is meant for isolated, larger lesions. So what do you do when now the lesion's much bigger, or the bone quality is pretty good and the patient doesn't want an allograft? There is something called ACI, autologous chondrocyte implantation. This is kind of the next level of regenerative medicine, and this has now been in existence for at least 15 or plus years, where it's a two-stage procedure. The concept being is that we're going to take some of your mature chondrocytes and we're going to harvest those in a single procedure. We're going to do an evaluation of the lesion. We're going to take a biopsy. Biopsy can be from the lateral femoral condyle. It can be from within the notch. And we're going to take those cells in culture. We're going to send them. The first company that was doing this was Genzyme up in Boston. We'd send those cells. They had a specific culture media and procedure to force these cells to duplicate and to make new cartilage. This was initially done in Sweden and then came to the United States. So they would culture the chondrocytes. At a certain time period, usually up to about 6 weeks, we would bring the patient back. We then perform an open procedure where we would open up the knee, take that lesion, make it into a nice sphere or whatever we needed to do. We would implant those cells, we'd implant those cells in a slurry, just cells in a slurry, and then patch it. Used to be with a periosteal sleeve. Now we would do it with more of a synthetic or cadaveric type patch. And this would close up. We'd keep people non-weight bearing. We'd put them on range of motion exercises. And over a period of time, those cells that were forced to become somewhat immature chondrocytes would then try to make the type 2 collagen, prepare the extracellular matrix, and would hopefully heal into type 2 cartilage. The problem is that we don't control the signals that those cells need to have that were in utero. So a lot of those cells just de-differentiated into type 1. But at the end of the day, through a lot of the studies, it showed that there was somewhat type 2-like cartilage, and these actually had pretty good results. And to this day, we still do them. But you can't control the cells. We force them to do something, but there's still a time frame from which they're trying to do what they do to the time that they might not do that. So there are advances to that, and we'll talk about that in a sec. But the next level of intervention for these is understanding, as I've tried to describe to you, that there is this macroscopic anatomy of just the articular cartilage. There's a specific arrangement of how cells are embedded into this collagen matrix to sustain it. So the next level of regenerative medicine is something called MACI, or matrix autologous cartilage implantation. So there's been a variety of substances that have been tried throughout the world. Again, it's a two-stage operation where there's harvesting of cells. Those cells are then cultured, but then they are impregnated into a three-dimensional transplant. So now there's a specific arrangement of those cells within the gel that's there. We come back, we kind of do the same thing, open procedure. It's a little bit easier where you actually just kind of put this jelly-like substance, this more dense-like, sponge-like thing into the defect, sew it into place, and we leave it at that. It is better long-term because I think there is something about that organizational construct that has been created through this three-dimensional model. But again, we're still not controlling the de-differentiation of those cells. So it becomes a problem. Some of the cells will just convert back to type 1. So we don't recreate really type 2 articular cartilage. So then the next level is tissue engineering. This is really where science is going to go to, because this is taking cells, both mesenchymal cells, which are cells that create connective tissue. We get them from the bone marrow, adipose tissue, synovium, and fetal cord blood. Now, the amazing thing is mesenchymal cells, and I don't understand exactly why, but in the adipose tissue, that is probably the largest site for mesenchymal cells, and it's easily accessible. If you've ever seen or had a bone marrow aspiration, it's a really painful and uncomfortable procedure, fairly invasive. Yes, getting adipose is too, to a certain extent, but it's a lot easier than the other ways to obtain tissue. You can get embryonic cells from cord blood, which again, these have this unlimited potential. And understanding, and it's not really of this lecture, but understanding the whole signal pathway from pluripotential cells to differentiation to collagen type 2 cells, is really a very complex process. They are figuring this out, understanding what growth factors need to be involved to make these cells. And I think this is really where we will be able to offer individuals a better option at treating articular cartilage lesions. The scaffolds that are there are also really important, because you have to understand that inside of the knee joint, the only, there's no blood supply, as we talked about. The only nutrients that come from cellular metabolism is from synovial fluid. So these new scaffolds that are being made with 3D printing are made of substances that also act as nutrient-based for the cells that are growing. So it's almost like you implant cells with, some type of food matrix that they'll start to eat that matrix, make new collagen, and just kind of recreate itself. Similar to what happens with an ACL. We implant a graft, it's essentially dead, blood supply comes in, and it just remakes itself over a period of time. That's where this so-called 3D printing and tissue engineering is really going to go to. And I think that over the next 5 to 10 years, we're going to see major breakthroughs when it comes to the treatment of articular cartilage injuries. So the postoperative care, these, are difficult because, again, we understand that we're taking something that's very tenuous, a slurry of cartilage cells, a microfracture where it's just basically a blood clot sitting on the knee, to some of these implants that need to have tender, loving care. So the vast majority of these, sorry for the typo, go non-weight bearing 4 to 6 weeks. We can do range of motion. The early studies and feelings of doing CPM machines is a great thing. Insurance companies don't pay for them, but we can, as therapists, as physicians, we can encourage range of motion, which helps massage it, induces some micro mechanical forces into that region, which can stimulate the cells to continue their proper process of differentiation and allow for maturation. We avoid impact loading for at least 4 to 5 to 6 months. The red flags for someone like you that might be treating any of these people would be obviously persistent pain, any type of persistent swelling that's inside of the knee. Sometimes the swelling takes a few months to go away, but persistent swelling and or a recurrence of any type of locking episodes of the knee. But these are very difficult to treat. Sometimes we see them incidentally, and we're not exactly sure how to treat them. But again, I would say that patient education, patient expectations, and goals really have to be drilled into their head so that they understand the full complexity, of what's happening inside of their knee. So that's all I have to say.
Great, thanks, Doc. I'm just going to go and see if we have any questions here for you. Okay, the one question said, did you say that this injury is common with ACL injuries? And if so, doesn't the ACL rehab have patients weight bear much too early to let this injury repair itself?
So I did say something along those lines, and I think these are all underdiagnosed. I think when you look at an MRI and there's a bone bruise that occurs classically on the lateral side of the knee, on the femur and on the tibia, you have to say to yourself intuitively, the cartilage that took the brunt of that force and now it's being seen in the bone has also been damaged. Now, an MRI can't pick up those acute injuries of the cartilage. All right, so the cartilage might look normal, but the cellular components that are in that articular cartilage, those cells have seen, stress and trauma, and it's probably over a period of time that those cells die. And that's why when you look at the long-term studies of ACL reconstruction in isolated ACLs, is that about 20 years down the road, pretty much everybody starts to develop arthritic changes on the lateral side and even on the medial side of the knee. So it's not something that you would treat acutely, because first of all, we can't diagnose it. Second of all, we don't know how to treat that because we can't treat the cells. We have no formula medication that you can inject inside of the knee that kind of takes the stress and injury away from those chondrocytes that are embedded in the cartilage. But it's just an understanding. So when I see a patient who has an ACL injury, I say to them, look, I can restore your stability, but even though everything else looks inside, your knee looks fine, there's a chance that 20 years down the road, you're going to have some arthritis that develops.
Great. I think that's the only question we have, unless anybody has any follow-up questions to what Dr. Cleon just touched on. Go ahead and throw them here. We are running a little bit ahead of schedule. I just spoke with our next doc, and he is finishing up patients, and he should be jumping on shortly. Dr. Cleon, I don't know if you have any closing remarks or anything else you want to touch on, since we do have a few minutes here to fill before the next doc jumps on.
I don't really have anything. I mean, it's a very difficult problem, and we have some solutions to it, but it's a process, and we're working our way towards that.
Got it.
Thank you.
No problem. Thanks for joining us today. We do appreciate it. We hope you're doing well in these times that we're going through, and that your caseload is picking back up.
Yes, it is. Slowly but surely.
Yeah, absolutely. I think we're all in the same battle here, right?
Right. We need to wear our masks and wash our hands. Absolutely.